Welcome to today's Melanin Table Talk. We're here back at you in honor of Black Breastfeeding Week 2025. And today I'm here with my colleague, Cristina Ramos, who leads our Community Perinatal Health Associate training at BRIC and a bunch of other amazing doula extraordinaire, birth worker, all that jazz.
A lot of fun
Newark
stuff.
and beyond. Yeah. So, Cristina, I'd love to start with you just telling us about yourself. Who are you?
Hey, Jasmine.
Hey.
So, I'm Cristina Ramos. I'm the Assistant Director for Healthy Beginnings at BRIC Networks. I do facilitate our CPHA and our CPHAL focus pathway as well. I love what I do. I'm really intertwined in our doulas day-to-day through our cohorts, and we have our Saturday classes, which are always a lot of fun. I really enjoy them, and we'll be in the hospital soon with cohort 2.
Yay.
So that's exciting.
Yay! Also from your lips to God's ears.
Yes, get in there.
So we'll talk a bit more about our awesome training in cohort 2 in a little bit, but first I'd love to just talk about your journey into maternal health. I know that you share with me that you have this unique family history that's a legacy of birth work. So can you talk about your grandma and your grandma's grandma and everyone in your family who's just deep into birth work?
Yeah, so it's really my aunt. She's one of my oldest aunts on my mother's side. My grandmothers helped in maternal work differently. So they were in birth work like the woman who would bring you soup after you delivered and checked on you, because it was a very tight, yes, and it was a really tight community. They birthed in another country where home births were normal. You would tell someone to go get, not even call, the midwife that was working with you, and she would mosey her way on down and check on you, and your family was there to support you. So that's how my aunt got into the work. She was there supporting her mother, birthing her siblings, and then her siblings birthing their children. She was the person there. And then when they came to the United States, she was the person who spoke the best English. She was the most educated at the time, and the person who had the desire to continue to attend the births. So she would, hey, do you want me to be there for you? Or you want me, how's your husband with it? I could be there with the both of you. She never had any formal training. There's no training that I know of that she took. And talking to her about her work, it's more of supporting the woman. I get to just be there with my niece or my sister or my goddaughter or whoever it is in the community that needs her there. And she just loves being there to witness birth. And it wasn't something I picked to do. It kind of fell in my lap, being my generation's, some first generation American born. And I'm the first person in my generation from my mother's side to have a baby. So I had my daughter at 17, and I kind of just fell into the role of doula work where people would ask me, come to my prenatals with me, or do you think this is a good doctor? Or how do I get on WIC? Do you think Medicaid's going to cover this? Or can I see a private doctor because this clinic really sucks? And helping them navigate the system and become a resource, and then starting to attend births. I mainly did postpartum visits, what I know now as postpartum visits. I took my first training in 2015, and then my eyes just opened to this being a career, and I went full-time in 2018, but I've done over 20 years of maternal work. And the most exciting part to me is that even without my influence, I don't think, or my pressure on my daughter, she is continuing our family's legacy, and she's also in birth work. She's a postpartum doula, and her work looks a little different than mine, and her focus on this work is very different than mine. Her focus is the moms. Her focus is I want to be there for them right afterwards, to stay up with them and talk to them at night, even if I'm there, even if that's not what I'm supposed to do, quote unquote, as a doula. You're supposed to take care of the baby and focus on that. She's like, no, I want to talk to them about what's bothering them and keeping them up at night, because we forget about mom so much once the baby arrives.
Yeah.
So that's
Thank you.
Really exciting for me.
And I don't. Okay, can I say her name?
Yes.
Okay,
yes.
Anastasia. Her name's Anastasia.
Yeah.
We know her. She's in the work. She's in our cohort.
Yeah,
so it's really beautiful for me to observe y'all acting professional like you're not related, but like Anastasia is an amazing
she
birth
says
worker
that
in her own right. Like she's awesome. She's so awesome. So it's lovely to see that.
I was like, I'm not doing your interview, just so you know. And she was like, why would you? That would be weird. I don't want anyone to think.
You're professional.
And then, we're in the cohort, and she's like, excuse me, Cristina.
Professor, can I interrupt for a second? It's very professional. There are like kids running between the floors to like go up. Yeah. But
she's like, I won't make you look bad, Mom. I promise.
But it's beautiful to see that, and she's awesome, and she is absolutely a doula and doing the work in her own right. Your grandma and other folks in your community who weren't the birth worker, like that direct support person, but doing things like postpartum care with like these specific soups or herbs or practices that folks engage in community. And we know a lot of times when folks end up here in America, in New Jersey, some of those things are lost, or if they aren't lost, they are frowned upon by our medical establishment. So can we talk a bit about, based off of your personal experience and your professional role as a doula working closely with healthcare in New Jersey, how do you feel like community-rooted practices fit in to our current healthcare landscape?
I don't think it fits in at all. I think supporting each other is something that was deeply rooted. It was celebrated that you were, Jasmine 2 doors down, but everybody knows Jasmine's about to give birth. Jasmine's having the baby. Oh, Jasmine, did they call the midwife? Oh, yes, the midwife's already on her way. We already talked, we're friends. I'm gonna bring her by some soup because her daughter's gonna let me know as soon as the baby's here. We're all gonna hear about it. That's not in our community anymore. I mean, we get the baby shower, but that focus is so on taking care of the baby after. There's not a lot of like, the diaper bash. The $1,000 strollers. So it's less about who's going to support you in birth than it is in your pregnancy, in your birth, in your postpartum. And that was already integrated in our culture. That was already integrated in our community. We didn't have to ask for volunteer labor. We didn't have to ask for underpaid labor. Granted, it was given, but it was just culturally rooted in what we did and just the love for one another. And
a community like care, not a, like you said, I'm asking you to perform unpaid labor, right? Because, and this gets to other conversations that we've had on this podcast with other folks and with each other on this podcast and in my office with the door closed, cussing, is this idea of like, you can't ask for help, or you feel like you can't ask for help because it's like, in this nuclear family, you're meant to be able to like manage all this with a partner. If you have a partner, you too are supposed to be able to hold it down.
Well, that's frowned upon too. You creating a family without a partner and then asking for help.
Yes, you shouldn't have gotten pregnant if you didn't have a man in your life to help support you when you're home. So that idea of those practices being forgotten, lost, not here, it impacts our physical health, our mental health, our emotional well-being, our baby's health and attachment, and all of these things that are really long-term and stressful.
And I feel like that's why policy needs to change more than this focus on the hospital changing. Because if our policies change, we're forcing the hospitals to change. So if we want to integrate more of our different cultures into our maternity care, you're going to have to make it policy. What are the things that we're going to integrate back without having to ask for this volunteer labor or underpaid labor?
And what are you allowed to do? Because sometimes, and this has come up interestingly in our cohort 1 and I think in 2, maybe a little bit more so, this idea of some of these indigenous or community-rooted practices or native, and I'll say native to a different non-American home country practices, or even things Black folks and brown folks do locally that are rooted in building a local legacy and culture here, are not allowed, right? So
co-sleeping.
Yes.
That's a big one in both cohorts.
Co-sleeping.
For back to sleep and safety.
Yes.
But things we know that breastfeeding families in other countries, it's supported, taught to do it safely if you're going to do it. And I feel like that's a big thing when you're a breastfeeding mom full time. Your baby's feeding every 2 hours at the beginning. You're lucky if you get that 4 hour stretch, if you're lucky. And side lying is the best way usually to do that safely. And you're told you can't co-sleep, and they instill so much fear in you instead of teaching you doing harm reduction work, teaching you how to do it properly and safely, and what not to do is much better than just ignoring it like it doesn't happen at all.
And we think about even like we don't support or not support anything really when we're talking. We just share information. But even a topic like co-sleeping, thinking about part of the danger to in America, because when we look at the statistics and how they're very different in other countries, we don't have postpartum support. So it is dangerous to not get any sleep ever and then fall asleep with your baby in your bed in a not safe way. If you were somewhere else where you had social support, other people would be holding your baby while you took a nap, or cleaning up your house so you didn't feel like you had to clean through the naps that your baby is taking. You could shower. You could like walk outside if you wanted to, like, let me breathe in some fresh air. Like, those things would be possible, and you wouldn't be overexhausted.
Absolutely. And going back to that community-centered care, that's what so many people did for each other. I'm going to go to Jasmine's house. I'm going to clean up her house. So when she gets home or when she wakes up today, everything is kind of cleaned up. The kids are taken care of. I put food in the fridge. There's some soup. She'll be fine for the night until I come back, or for a few nights.
Yeah.
And that's no longer here unless you...
Maybe you get a meal train for like a week.
If you're lucky.
If you're lucky. And it's expensive, right? It's like,
and the more kids you have, the less people do for you.
You don't need that. You can reuse that onesie you've had for 15 years.
Again.
You could use that again. Did
do
you
that
wash
again.
out that diaper? That's not reusable. You could use those. They're from 10 years ago. Bring them back out. But that's the way that we often treat our birthing people, and it sucks. It's sad. It hurts. It makes it pretty clear why all of these horrible things are happening in our long-term, like, maternal and infant outcomes, right? And to your point, around policy, but also just the restoration of community care and systems and communities that are connected. It's not just like, we're not saying that hospitals and doctors are like doing these horrible things. Like, the entire system is not set up
it's not an individual.
any of these things to happen. Like, you having to go back to work in 4 weeks is unhinged, right? Like,
no parental leave.
Yes.
Just
or if you're relying on the state leave, still, like, we're so thankful for that. And it's not your full salary, right? So, like, people got to go back to work. Like, I got to pay these bills. So
the bills don't cut back 20.
They don't. They sure. I wish they did.
They keep coming,
but they sure.
They don't say congratulations, you had a baby. We're gonna knock off 20%.
Absolutely not. Absolutely not. And we're laughing because that's all we can do. So we don't cry.
Us to work through this.
And there's just so many systemic barriers in the way. But it's really beautiful to hear that you have been able to translate what your family does into a career.
Yes.
And maintain that. So can you tell us a little bit, tell me, it's just me here. I am like multiple people, but it's technically just me. So can you tell me, like, how that shows up for you, like, very specifically, like, how do you bring that legacy of birth work and your cultural practices and all of the things that you know experientially and merge that with your professional training and do your job? And teach new doulas what to do.
Continuing education, being thirsty for more knowledge, being a mom really helps me see the perspective of the birthing parent, and in different periods of gestation, and also like preconception, when you're worrying. I've been through every kind of scenario. I feel like there are a few I haven't, thank goodness, but I can share from that perspective, or also relate and have some empathy and be able to say, I understand where you're coming from. I don't know what you're feeling in this moment, but I can understand how it felt for me. Talking about loss with people has become much easier. I've taken a lot of trainings and bereavement and been able to support a lot of people through their own terminations and losses for whatever reasons they've decided. So that's really helped me weave into my work the different aspects of birth work, because we're not just looking at a pregnant person. Like, there's so much that comes before. We're not talking about preconception or people who have difficulty getting pregnant. People who lose pregnancies in the first trimester, the second trimester, or the third trimester with stillborns. Like, how are we supporting them? There's so many different variations. and things that could happen. So I like that's why I say thirst for knowledge, being very well educated and doing background work. But I feel like my motherhood, my thirst for knowledge, continuing education, really diving into this work of policy and birth equity and being in the rooms with funders and policymakers just helps put it all together for me. And that's I think that I answered your question.
You did. Yeah, it's a lot to catalog.
Yeah,
like it's like
because it's my life.
Yeah, your real life.
It's really my life.
The things that your family does. Like this is again like your intergenerational
we
calling.
Have pelvises around the house and teaching breast all over the place with all these little boys in my house, and they're like, "I like your pelvis. What is this called right here?" And we're talking anatomy in the house. My daughter's in birth work, so it's like, where are you going to be next week for Black Breastfeeding Week?
Yeah.
Like, so that's a lot of our lives.
I mean, maybe she'll be on Tuesday at our little thing we're having. She coming?
She has children, as long as she can bring them.
Okay. Let's talk about that. We're having many events in honor of Black Breastfeeding Week, and one is a really important lactation conversation we're having with an intimate group of 10 to 15 stakeholders, but really to dig into New Jersey's breastfeeding strategic plan and think about how we inform our personal community perinatal health associate lactation pathway. So let's hop into that a little bit as we roll down and wind down our conversation. I think folks in this world who have listened to this podcast before kind of know that we are training what we are calling community perinatal health associates. So folks come out with a doula certificate, but what they also get is additional concepts around public health, so social determinants of health, enhanced lactation happens in this course, trauma, a more intentional thoughts about how to support teens. Like there are some more pieces there. And we also add in 100 hours of experiential hands-on learning that happens in hospital and clinic settings, in addition to 20 hours of continuing education and community-based work. So super robust. It's long.
And
it takes forever.
It's long.
It's like 6 months long. It's like a very long, very intense training, but it's completely free and it's awesome. But as we were thinking out, and Christina and I spent a lot of time like chatting those chats result in very important strategic plans about what we want this to look like. And as we're digging into the perinatal workforce, we know that doulas are a super important, critical piece, and there are other pieces of the workforce that we feel like, as a nation, as a state, we haven't been putting as much priority on and paying as much attention to. And we're not going to get into the big concept right now, but lactation is a public health issue, right? Like there are so many long-term benefits of lactating, of feeding your baby at the breast or pumping, which we're not going to get into all the science right now. I'd love to get into the science, but not right now. But we created what we're calling the CPHAL lactation pathway to get people on that path. So can you just tell us high level, like how we've started to chart this out and what it started to look like in practicality, because we're in it.
Yeah, so we had a lot of doulas in our last cohort really interested in pursuing their education and career and focusing on lactation. And it really got us thinking about how we could help them get to the next step. So the next step for them would be CLC, which is Certified Lactation Consultant, and counselor.
And I'm only saying that because we confuse our consultants.
Yeah.
Right?
So I do it all the time. So I am going through this course with LER myself, and I thought it would be great for us to add in this focus. We worked closely with the IBCLC, the Internationally Board Certified Lactation Consultant at university. Makiba, and she was just wonderful. She really integrated our doulas in her lactation work at every clinical round. So they were able to not just support the clients in the way they thought a doula would, but they were able to be in the scope of a peer breastfeeding counselor, which was our course before. And that was the reason that we had so many cohort members that wanted to focus on lactation. We already had a focus pathway, but we knew that that wouldn't provide them with any additional income. Honestly, the only place that they would be able to work would be at WIC. So we said, how can we make this sustainable? How can we add this to their certificates? How can we make this their resume? How can we make this more robust so that their salaries increase? You can charge more, or you can take private clients that focus just on lactation. It's a great way to add into your doula work to increase your rates. I know I heard Shimon a while ago talking about pricing, and adding this into her scale will definitely increase her rate. So I I was like, we really got to focus on lactation. I don't think midwifery is the way to go. There's a whole focus on that, and the midwives are doing that, and they're doing a great job right now. Let's work with the organizations that are focusing on lactation. And we started talking to different organizations that facilitated CLC certifications, and we decided on LER, and we decided on a study group more than us conducting the training, because there were people already doing the work and they were doing a great job. Why recreate the wheel?
Recreate the wheel.
And we're really excited to get started because they'll also be focusing, like you said, in the hospital. So once they get their requirements in, they can solely focus on clinical care under the watch of a IBCLC. The nurses are there as well. They will not be acting as CLCs, but they will be acting as peer breastfeeding counselors in the hospital setting, just to get more experience and be able to really provide good care to their community.
Absolutely. And this is like also, it's such an important gap too, because as we think about an IBCLC, so like you said, International Board Certified Lactation Consultant is the highest credential really you can get in lactation. And often those are nurses. That is a good salary, right? So we also know that some of our folks are moving on this pathway towards that, but there are stops along the way. And this is a really important stop for people to go along. But also, we don't have a ton of IBCLCs in New Jersey. And we're thinking about you like giving birth in a hospital. You give birth on Friday night, right?
Yeah.
You might not ever see that IBCLC because the way that staffing works, it's like during the week. But maybe you can see a CLC, or maybe you can hire a CLC to come to your house for an affordable price that day that you get out of the hospital. So it really fills this gap in between that IBCLC and nothing, right? It's like as we think about breastfeeding is really hard. Like we say that's this natural thing, and it's totally natural, but it's not intuitive all the time, right? Like it's not the easiest thing in the world, and you need some support.
Yeah. I tell them it's like a dance with someone you've never danced with before.
Yes.
So imagine you've never danced this dance, and then you're dancing it with someone who's also never danced this
and then
dance.
When I watch the YouTube video, your feet are smaller than that, and my dress is tighter than that person had. So I've got movement restrictions, and you've got stuff going on. That's my dance reference. But like, it's different. Every baby has a different mouth and a latch, and your nipples are doing different stuff. Like, it's different.
It'll feel differently for you too than it feels for somebody else.
Yeah, but we say they make it who the royal they think that say that, oh, a little pain is normal. It's not.
It's not.
Pain is common, but not normal. That's why we need important lactation professionals to fill this gap so that we can increase breastfeeding rates, so that we can contribute to reductions in ovarian cancers and all of these things that are tied to breastfeeding, especially in Black birthing communities. That's really important as we think about health disparities.
Yeah, and that's why we have this pathway, kind of get more CLCs to fill the gap within our community. And
we need folks to get paid. To your point too, like highlight, double click on that. Doula work is so important, and if you're not charging high rates, and I'm saying high, I mean high like out of that person's pocket, not high for the value that you deserve, but that's not covered by insurance, it's hard to make a living, and people end up being really scrappy and doing all these different things when it's like I'm hearing from y'all, it's like hard to just focus on being a doula unless you have a great mix of people who can pay $3,000 out of pocket, which is not everyone. Lactation helps us move along that path to increasing income.
I feel like there is a gap that most doulas don't look at. There are a certain number of doulas that have met that definitely look at that gap as being a much bigger gap than our Medicaid clients that are underinsured or uninsured, and that's why they have Medicaid, and are people who can spend $10,000 a pop on a doula. There is this middle gap of people who have commercial insurance and are still willing to, I'll pay out of pocket for my doula because this is the doula I want, and I know already, I've done my research, my homework. I know I want a doula. I know the reasons I want a doula. Me and my partner are on the same page, whoever your partner is, and they will pay the $3,000. So I find that we put this huge emphasis on like doing other work and finding other places to source, which is great. Multiple streams of income are amazing, but it's not if you're burning yourself out. And the burnout rate for doulas is under 5 years. And I've felt crazy burnout doing this really full time. By yourself, you're doing predominantly of the work. You're not just admin, girl. You're not just the doula. You're not just the peer breastfeeding counselor. You're not just the placenta encapsulationist, the CBC, the childbirth educator. You're wearing all these hats, plus you have to pay your taxes. You have
Wouldn't
to do
be
your
me.
own
I would
payroll.
be like the IRS would be after me. I would be like,
insurance.
I haven't paid the bill. I wouldn't be me.
So on top of taking 6 to 8 births a month, right? Let's say that's 4, 5, 6, whatever. Anything over 4, 1 a week, maybe.
That's too much.
Yeah, you're gonna burn out. So creating different sources of income to come in from one thing, like your doula work, mixing in your Medicaid clients with your clients who can pay you top dollar, and then your clients that are like in the middle there, you might get reimbursed by insurance, or they're paying out of pocket, or they're paying with their FSA money, and they planned for this, which is always awesome. You have those gaps. It's kind of figuring it out is what I'm finding from our doulas. It's like, how do I set this up so that I can be successful? But they're newer doulas, I find, are more afraid to charge at all. They're scared to talk about the conversation of money.
It's hard.
And
it's
like, what
hard,
do I
especially
charge?
because when we talk about it, it's like this like divine purpose or calling. It's like, oh, this is what I meant to do. But like, you're meant to pay your bills and have a roof over your head and like.
When it was 1952 and we could have been home and I could have come to your house. You know, because our husbands were away working hard and they brought their money home, bills. Paid all the little bills we had.
I'm doing I'm doing a manicure. I'm taking a break from my manicure to support your birth, okay?
Maybe we could have had that, but in 2025, with the price of gas and electricity and everything, food going up, I didn't think this 5 years ago. I didn't think it 10 years ago. I didn't think it 15 years ago. The minute I decided to make this a business, I didn't look at it that way. And I do find it hard for a lot of doulas to like.
Yeah, but because business is a skill. People get whole MBAs, right? Like, we talk about this all the time. It's like when you are charged with being an entrepreneur as a doula, it's not the birth work that you just have to be an expert in. It's like you said, the taxes and social media and administrative work and submitting claims. Like now you're a Medicaid claims person. Like
you're a biller.
You're a biller. You're a Medicaid biller. There's just all of these things that come up. And what we are trying to support folks in doing or entering the workforce is remove some of these administrative barriers. And also, like, how do we get our folks using a system that we are able to pay for them so they don't have to worry about all that nonsense and just focus on the work? Because not everybody wants to be a business tycoon, right? Like,
some people like to be sole proprietors and just do this as their passion work. Yeah. But you still have to have your ducks in a row so that Uncle Sam doesn't come looking for you.
I don't want anyone coming to get y'all. I don't want anyone coming to get y'all. Yeah, so we are really excited. Like, it's the first cohort of CPHAL and really wanting to support those folks on a greater pathway, because what we also do know is that our doula training is really rooted in practice, experiential learning, reflection. It's content-based, but we don't have exams. We don't have tests, right? Yeah. The CLC has exams and it has tests. So I don't want to the glossing over like a study group. It's not just a study group. It is really ensuring that people are on track and feel confident in the knowledge that they're learning so they can get through this process and pass this test, because there is an exam at the end so that they can have that piece of paper. It's hard. It's hard.
It's hard, and you have the camaraderie of the other people going through the same thing at the same time as you, which is helpful.
Yeah. And you.
And me going through at the same time with them also.
Yeah. So if there was one thing, Cristina, as we wind down, what you would want someone who wants to enter the lactation workforce right now, like from the very beginning, what would you say to them? What kind of advice would you give to that person?
Have you ever breastfed?
I'm in my role. My name is Amy. And
Amy.
No, I have not breastfed, but I am passionate about lactation.
What makes you passionate about lactation?
I'm going to pretend to be me, but I'm Amy. My background's in public health, and I know that the long-term health benefits.
Oh, awesome. Have you been to a WIC office?
No.
I think
What's
you should
WIC?
Let's talk about WIC, Women, Infant, Children. It's a program that is state and federally funded, and they supply women who have children or are pregnant, I think men too, You bring your financial information, and they'll give you subsidies to purchase food, formula, but they also help you with breastfeeding. They usually have an IBCLC, which is an internationally board certified lactation consultant on staff, and some CLCs, some certified lactation counselors. They may have peer breastfeeding counselors too, and I would suggest you start there. You might want to volunteer or work there as a peer breastfeeding counselor so you can become familiar and really be integrated in the lactation field and see what you're getting yourself into before you make a big commitment like you want to be a lactation consultant.
So your advice would be to start low threshold. Like
especially if you haven't breastfed. I want you to see other people breastfeed. You're in public health. You should go to a WIC office, see what they do at WIC, meet the IBCLCs, the CLCs, the peer breastfeeding counselors. How do they work? And see if that's really a field you want to get into. And if you're still as passionate about it when you're in the work helping a mom who's exhausted. And can you truly empathize and be able to help her? Yeah.
Cool. So starting lower, not going straight for that like CLC certification. It's like starting at an entry pathway to see what it's like. And that's also how we're trying to design this training. We'll have more conversations around training and all of that stuff, but we really want people to be able to enter our training in general, the CPHA, as an entree to maternal health, right? Like you might want to be a nurse or be an OB or be something else, but this is a place for you to get a ton of information around perinatal health, infant health, social determinants of health, trauma, like some of these concepts, and then be in a hospital and see how those things work on a labor and delivery floor. And then, like maybe you're like, I don't want to see all this stuff happen. I don't want to be on the floor. Maybe I do want to just work in the, not just, but I want to work in the WIC office or the outpatient setting, not on the labor and delivery floor.
Yeah, it gives you the opportunity to make a decision based on your lived reality, like what's actually happened in your life. You can say, I didn't really like that, because I've already been in that experience. Versus like, let's go 100 miles per hour straight toward that goal, and then get there and be like, this isn't really what I wanted it to be, or doesn't look the way I thought it would. Yeah, at least you're in the field. I mean, we have people in our cohort who already are trained doulas. We have people in our cohort who are on their way to become midwives. We have people in our cohort who are nurses. We have people in our cohort who this is their first time in birth work at all. So
research.
Yeah, we have research, public health.
They run the gamut. It's like
so we have a very robust, just like our first cohort was very different. This cohort is more different because we've included people who've already had their doula certificates with other organizations, but they want to focus on being Medicaid providers.
But they're learning, which I have, like, that's been, I feel like, very fulfilling. Like, those folks have been like, I am fully trained, and I am still learning things when it comes to this class. So shout out to Cristina for facilitating
thank you.
An amazing course. And is there anything else you want us to know at this Melanin Table Talk?
No. I think we covered everything.
We've covered every single thing.
Yeah, I think we covered everything, and then some.
And then some. But big buckets of takeaways. Like, I love just hearing about your family history and the legacy, and your daughter being in the work, and your aunt being in the work, and just how this all has come together for you as a career. But you have found a way to carve out a place for yourself where you're not getting burnt out, because now you're on the teaching administrative side while still absolutely being in the work. So you can, I hope, take care of yourself in a different way where the burnout, it looks different. It looks different.
Very different. Yeah, it's not the same. I mean, being a birth worker, you're on call, at least in doula work and midwifery work. So if you're taking 4 to 6 births a month, it's really hard for self-care. It has to be, and then you have your kids, and then you have admin, and then you got to go collect those checks.
That stuff doesn't go away. That stuff doesn't go away.
Drop off packages, all the other things that get in there.
The
so it's very different now. Life is very different.
Well, we are so glad that you're with us. Thank you.
Thank you
for having Cristina. Seriously, Cristina's amazing. You're a great trainer. We love you, and the cohorts have been loving you. And I think we've come to the end of our Melanin Table Talk today.
Oh, awesome.
Love chatting with you.
Thanks for having me.
Thanks for being here. Thanks, y'all.